We got like a pediatric theme going here with Filter Baby and then, which is great. We're going to talk a little bit about pediatric skincare here real quick. My name is Seth Reno, so I'm the CEO of Arkayli Biopharma, and our company is really dedicated to developing better therapies for pediatric vascular anomalies. It's the fancy word for infantile hemangiomas. The challenge here, really the problem that's outlined, is that the only available therapy today that is standard of care is oral beta blockers, and they have very serious side effects because they're systemically absorbed. And so the challenge with that is most parents understand that beta blockers are used in older populations. And because of the systemic absorption of that, they're not comfortable with their providers, prescribing that at an early age of anywhere between 3 weeks and 3 months of age. So the result that we start to see is that there's a wait and see attitude to treating these infantile hemangiomas. And if left untreated, you can see the pictures between 1 month and 3.5 months of age. There is a drastic change. They can double, quadruple in size. They can become ulcerated. If they're located near the eyes, ears, or nose, they can become functionally structural in nature and cause a lot of damage as they continue to grow.
Are these detected in the womb too, or just when they're first born?
Yeah, they come out and you can actually, because they're superficial, you can actually see them. But some of them will develop as late as 1 month of age and start to, almost the size of a little pimple. It starts to grow, and then it starts to erupt in the first 3 months of age, or when about 80 to 90% of the growth takes place.
Oh.
So the current therapies available is there's actually only one drug that's been approved by the FDA. It's oral propranolol. It was approved back in 2014 by the trade name hemangiol. Timolol eye drops are also used off-label. There's been a trend to using more timolol because parents feel a little bit better instead of giving systemic, oral therapy by putting, the drops on the skin, but they are absorbed just as much as the oral suspension is. And what Arkayli is working on is a once daily long-acting gel. And the trick to this is you can see that the half-lives are quite different. We have an ultra short half-life of anywhere to 4 to 9 minutes versus 3 to 6 hours. So we're concentrating that gel at a higher level of medication and applying it just to the hemangioma. So you're getting drug only where the hemangioma is located and it's not systemically absorbed. We've actually created this in a formulation that's clear topical, self-formulating gel. It's designed specifically for sensitive skin to be put right on top of hemangiol. We have been able to get 24-hour release out of that, actually going quite a bit beyond that. And esmolol is really one of the only beta blockers out there that has this ultra short half-life of 4 to 9 minutes. And it's really metabolized pretty quickly in the red blood cells, which eliminates systemic exposure. And the challenge with systemic exposure, some of the side effects that you can get are cold limbs, hands and feet. You can become hypoglycemic. There is a CNS effect to this, so you'll have kids that have terrible sleeping disorders. And then on the more serious end, there can be seizures or bronchospasms associated with it as well. So the market, from a segmentation standpoint of view, about 55% of the cases that physicians see should be treated because they're going to have some level of sequelae, usually scarring or some type of function within the hearing loss, or being able to breathe through their nose, or be able to eat with their mouth. And you can see out of each year, about 170,000 babies are born in the U.S., which is about 4.5% of all births each year. And out of that, 12% of them have more severe complications, like we saw on slide 3. 33% will have no sequelae and it will go away. But it's not like a pimple. It doesn't go away within a month or two. These infantile hemangiomas can stick around for a number of years. They're fairly serious. Currently, out of that, you can see 55% of the kids, need to be treated. So we went back and looked at actual prescriber level data, and we see that only 27% of infants, when you look at the prescriber level, are actually being treated. And so there's a gap here, not only the technology or the innovation of the drug, but really the reason why these kids aren't being treated is the wait and see, where physicians are really uncomfortable from a primary care perspective. and treating these, 3 to 5 week old infants with a beta blocker. So they'll defer that into a specialty referral to a dermatologist. There's about 60 to 80,000 pediatricians around the U.S., but there's only about 600 pediatric board-certified dermatologists that really specialize in infantile hemangioma. So there's a little bit of a bottleneck and a disconnect, and there's a pretty big, bottled up unmet need. And you can see the gap between 27% and the 55% that really need treatment. It's getting better. In 2019, American Academy of Pediatrics came out with some guidelines in using propranolol for the use of treating infantile hemangioma. And so there is a nice growth curve, but there's still a ways to go. From a patient funnel size and the size of the market, we start off with 170,000 kids. 55% of them need to be treated for severe sequelae or moderate sequelae. Out of that, about 10% will have dispersed infantile hemangioma, which will be appropriate for the required systemic treatment. So when you remove that out, we believe that we have an eligible population each year of 84,000 kids that can be eligible for topical therapy. We dollarize that times the branded cost for hemangiol that's in the market now at $957 a month, and that's just under $1 billion. So it is a fairly big market. One of the things that our team is always looking ahead at phase 1 and phase 2 and thinking about our primary endpoint and our co-primary points that are really important to prove statistical significance in these double-blinded randomized trials. And we actually were awarded a grant from the University of Wisconsin to work on this technology to quantify co-endpoints and primary endpoint measurement. This is a technology that wasn't available a number of years ago. It's called Canfield 3D photography, and it actually helps you size out the reduction in size of the infantile hemangioma and creates a volume reduction area of that so you can see the statistical significance. It also is able to track the level of redness and the thickness of the infantile hemangioma. So that was a really a great grant to receive because it's non-dilutive sources of funds, and it helps us move along nicely in that area for our clinical studies. Intellectual property wise, we filed a patent back in the fall of 2019. We also have an orphan application in as we speak. Orphan is important because an orphan designation for an orphan subset designation allows you 7 years. And because this is pediatrics, you get an additional 6 months, so you get 7.5 years. And we have method claims running out for infantile hemangioma to 2037. This is our proven leadership team. Everybody has at least 20 to 30 years in either commercializing orphan products in the pediatric market, dermatology, transdermal delivery. But I would like to give a special call out to Dr. Beth Drolet. She's one of our co-founders. She is a pediatric dermatologist. She chairs the Department of Pediatric Dermatology at the University of Wisconsin. She sees kids every week. She has about 400 kids that run through our clinic each year with infantile hemangiomas. She's been on all the key studies for any therapy treating infantile hemangiomas for the last 25 years. And one of the things that is clearly relevant every week, I get calls from her, I see pictures from her. There is a big gap and an unmet need to come out with a drug that is non-systemic, that's topical, to start to treat this disease state early so that these kids don't have long-term sequelae. So right now we're in the middle of raising a $1 million seed through the Simple Safe. We have a 20% discount with a cap. We've already started to create our formulation. We are scaling our preclinical drug supply and preparing them for the mini pig study, which is down below. That is our proof of concept that this drug will not have systemic absorption. We've already started work on the pre-IND meeting and scheduling that and the IND templates needed. So in the last few months since May, again, we've been awarded $70,000 grant from U of W to study the Canfield 3D. We're also a winner in the Innovate Children's Healthcare Network Challenge, which is really exciting. So just in the interest of time, if anybody has any questions, here's my information to contact us. You can check us out on the website at arkayli.com. But we are, our team is out there in the interest of coming out with new innovative therapy, much safer, so that we can really put an end to the #1 cause of preventable childhood disfigurement, and that is untreated infantile hemangioma.